Therapy-resistant depression, TRD. Introduction. Therapy-resistant depression, TRD, also known as treatment-resistant depression, represents a significant and challenging subset of major depressive disorder, MDD. Despite the availability of numerous antidepressant medications and therapeutic interventions, a substantial proportion of patients with depression do not respond adequately to standard treatments. TRD is typically defined as a failure to achieve remission after at least 2 adequate trials of antidepressant medications from different classes. This condition imposes a heavy burden on patients, their families, and healthcare systems, and it underscores the need for a deeper understanding of its underlying mechanisms and more effective treatment strategies. Understanding depression. Major depressive disorder, MDD. Major depressive disorder is a common and debilitating mental health condition characterized by persistent sadness, loss of interest or pleasure in most activities, significant weight changes, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue, feelings of worthlessness or excessive guilt, diminished ability to think or concentrate, and recurrent thoughts of death or suicide. The World Health Organization, WHO, ranks MDD as one of the leading causes of disability worldwide. Pathophysiology of depression. The pathophysiology of MDD is complex and multifaceted, involving genetic, biological, environmental, and psychological factors. Key components include 1. Neurotransmitter imbalance. Dysregulation of neurotransmitters such as serotonin, norepinephrine, and dopamine has been implicated in MDD. Antidepressant medications typically target these systems to restore balance. 2. Neuroplasticity. Depression is associated with decreased neuroplasticity, particularly in brain regions like the hippocampus and prefrontal cortex. Neuroplasticity refers to the brain's ability to adapt and change in response to experiences. 3. Inflammation. Emerging evidence suggests that systemic inflammation and increased levels of pro-inflammatory cytokines may contribute to the development and persistence of depression. 4. Genetic factors. Genetic predispositions play a significant role in MDD, with heritability estimates around 40 to 50%. Specific gene-environment interactions also contribute to individual susceptibility. 5. Stress and HPA axis. Chronic stress and dysregulation of the hypothalamic pituitary adrenal (HPA) axis are commonly observed in depressed individuals. This axis regulates the body's response to stress and can impact mood and behavior. Defining therapy-resistant depression. Criteria and definitions. TRD is generally defined as a failure to achieve remission following at least 2 adequate trials of antidepressant medications from different pharmacological classes. Adequate typically refers to appropriate dosage and duration of treatment. The exact criteria can vary across studies and clinical guidelines, but common elements include 1. Medication trials, at least 2 trials of antidepressants with different mechanisms of action. 2. Duration, each trial should last for an adequate period, usually 6 to 8 weeks. 3. Dosing, medications should be administered at recommended therapeutic doses. For PA assessment, standardized tools and scales, such as the Hamilton Depression Rating Scale, HDRS, or the Montgomery-Åsberg Depression Rating Scale, MADRS, are used to evaluate response. Prevalence and impact. TRD affects a significant proportion of individuals with MDD. Estimates suggest that approximately 30 to 50% of patients do not achieve remission with initial treatment attempts, and 15 to 30% may meet criteria for TRD. The impact of TRD is profound, leading to 1. Increased disability, higher levels of functional impairment and reduced quality of life. 2. Higher healthcare costs, increased utilization of healthcare resources, including hospitalizations and emergency visits. 3. Greater comorbidity, higher rates of comorbid psychiatric and medical conditions. 4. Increased suicide risk, elevated risk of suicide and suicidal behavior. Risk factors for therapy-resistant depression. Several factors have been identified that may increase the risk of developing TRD. 1. Early onset. Depression that begins at an earlier age is often more chronic and difficult to treat. 2. Severity and chronicity. More severe and longer-lasting depressive episodes are associated with higher resistance to treatment. 3. Comorbid psychiatric conditions. Co-occurring anxiety disorders, substance abuse, and personality disorders can complicate treatment. For medical comorbidities, chronic medical conditions such as diabetes, cardiovascular disease, and chronic pain can impact depression treatment outcomes. 5. Genetic factors. Certain genetic profiles may predispose individuals to poorer responses to antidepressants. 6. Psychosocial stressors. Ongoing stress, trauma, and lack of social support can hinder treatment effectiveness. Biological mechanisms of therapy-resistant depression. Understanding the biological underpinnings of TRD is crucial for developing targeted treatments. Key areas of focus include neurotransmitter systems. 1. Serotonin system. Traditional antidepressants, particularly selective serotonin reuptake inhibitors, SSRIs, target the serotonin system. However, alterations in serotonin receptors and signaling pathways may contribute to resistance. 2. Norepinephrine and dopamine. Dysregulation in these neurotransmitter systems is also implicated in TRD. Medications such as serotonin norepinephrine reuptake inhibitors, SNRIs, and dopamine agonists are often explored. Neuroplasticity and neurogenesis. 1. Brain-derived neurotrophic factor, BDNF. BDNF is crucial for neuroplasticity and neurogenesis. Reduced BDNF levels and impaired signaling are observed in TRD, leading to decreased neuroplasticity. 2. Neurogenesis. Impaired neurogenesis, particularly in the hippocampus, is associated with chronic stress and depression. Enhancing neurogenesis is a potential therapeutic target. Inflammatory processes. 1. Pro-inflammatory cytokines. Elevated levels of cytokines such as interleukin-6, IL-6, and tumor necrosis factor alpha, TNF-alpha, are observed in TRD. Inflammation can affect neurotransmitter metabolism and neuroplasticity. 2. Microglial activation. Activation of microglia, the brain's immune cells, contributes to neuroinflammation and is linked to depression and TRD. HPA axis dysregulation. 1. Cortisol levels. Abnormal cortisol levels and HPA axis dysregulation are common in TRD. Chronic stress and altered cortisol secretion impact brain function and mood regulation. 2. Glucocorticoid receptors. Impaired glucocorticoid receptor function affects the body's ability to regulate stress responses, contributing to TRD. Psychosocial factors in therapy-resistant depression. While biological factors play a critical role in TRD, psychosocial factors also significantly impact treatment outcomes. These include 1. Trauma and abuse. History of trauma or abuse can lead to chronic stress and neurobiological changes, increasing the risk of TRD. 2. Social support. Lack of social support and isolation are associated with poorer treatment outcomes and greater resistance to therapy. 3. Cognitive patterns. Negative cognitive patterns, such as rumination and hopelessness, can perpetuate depression and hinder treatment response. 4. Socioeconomic factors. Low socioeconomic status, unemployment, and financial stress are linked to higher rates of TRD. Assessment and diagnosis of therapy-resistant depression. Accurate assessment and diagnosis of TRD are essential for developing effective treatment strategies. Key steps include comprehensive evaluation. 1. Clinical interview. A thorough clinical interview to assess the history of depression, treatment attempts, and response to medications. 2. Standardized scales. Utilization of standardized scales such as the HDRS or MADRS to quantify depression severity and treatment response. 3. Medical and psychiatric history. Evaluation of comorbid medical and psychiatric conditions that may impact treatment. Biomarkers and genetic testing. 1. Biomarkers. Research is ongoing to identify biomarkers that can predict treatment response and resistance. These may include inflammatory markers, genetic polymorphisms, and neuroimaging findings. 2. Pharmacogenetics. Genetic testing can provide insights into individual variations in drug metabolism and response, guiding personalized treatment approaches. Treatment strategies for therapy-resistant depression. Given the complexity of TRD, a multifaceted and individualized approach to treatment is essential. Strategies include pharmacological interventions. 1. Switching antidepressants, trying different classes of antidepressants, such as switching from an SSRI to an SNRI, tricyclic antidepressant, TCA, or monoamine oxidase inhibitor, MAOI. 2. Combination therapy, combining antidepressants with different mechanisms of action, such as adding an atypical antipsychotic or a mood stabilizer. 3. Augmentation strategies, augmenting antidepressant treatment with other medications, such as lithium, thyroid hormone, or psychostimulants. 4. Novel agents, exploring novel pharmacological agents, such as ketamine and esketamine, which have shown rapid antidepressant effects in TRD. Psychotherapeutic interventions. 1. Cognitive behavioral therapy, CBT. CBT is effective for many patients with TRD, focusing on altering negative thought patterns and behaviors. 2. Interpersonal therapy, IPT. IPT addresses interpersonal issues and social functioning, which can contribute to depression. 3. Acceptance and commitment therapy, ACT. ACT encourages acceptance of negative thoughts and feelings while committing to valued actions. 4. Mindfulness-based therapies, mindfulness-based cognitive therapy, MBCT, and mindfulness-based stress reduction, MBSR, can help patients develop mindfulness skills to manage depression. Neuromodulation techniques. 1. Electroconvulsive therapy, ECT. ECT remains one of the most effective treatments for severe TRD, particularly for patients with severe or psychotic depression. 2. Repetitive transcranial magnetic stimulation, RTMS. RTMS is a non-invasive technique that uses magnetic fields to stimulate specific brain regions involved in mood regulation. 3. Vagus nerve stimulation, VNS. VNS involves implanting a device that stimulates the vagus nerve, which can help regulate mood. 4. Deep brain stimulation, DBS. DBS involves surgically implanting electrodes in specific brain regions to modulate neural activity. This is an experimental treatment for TRD. Lifestyle and behavioral interventions. 1. Exercise. Regular physical activity has antidepressant effects and can enhance treatment outcomes in TRD. 2. Nutrition. A balanced diet rich in omega-3 fatty acids, vitamins, and minerals can support brain health and improve mood. 3. Sleep hygiene. Addressing sleep disturbances through good sleep hygiene practices and, if necessary, pharmacological interventions. 4. Stress management. Techniques such as yoga, meditation, and relaxation exercises can help manage stress and improve mood. Integrative and complementary therapies. 1. Acupuncture. Some evidence suggests that acupuncture can be beneficial for patients with TRD. 2. Herbal supplements. Certain herbal supplements, such as St. John's wort and S-adenosilmethionine, SAMe, may have antidepressant effects, though caution is advised due to potential interactions with medications. Emerging research and future directions. Research into TRD is ongoing, with several promising avenues being explored. Novel pharmacological targets. 1. Ketamine and esketamine. These NMDA receptor antagonists have shown rapid antidepressant effects and are being studied for their potential in TRD. 2. Psychedelic compounds. Substances like psilocybin and MDMA are being investigated for their potential to treat TRD through mechanisms involving neuroplasticity and emotional processing. Personalized medicine. 1. Pharmacogenetics. Advances in pharmacogenetics may enable more personalized treatment approaches, optimizing medication choices based on individual genetic profiles. 2. Biomarker development. Identifying reliable biomarkers for TRD can aid in early diagnosis and the development of targeted treatments. Neuroimaging studies. 1. Functional and structural imaging. Neuroimaging studies are providing insights into the brain regions and networks involved in TRD, informing the development of novel treatments. 2. Connectivity-based approaches. Techniques like resting state functional MRI, RSfMRI, and diffusion tensor imaging, DTI, are being used to study brain connectivity patterns in TRD. Conclusion. Therapy-resistant depression is a complex and multifaceted condition that poses significant challenges to patients, clinicians, and researchers. Despite the availability of numerous treatment options, a substantial proportion of individuals with depression do not achieve remission with standard therapies. Understanding the biological, psychological, and social factors that contribute to TRD is crucial for developing more effective and personalized treatment strategies. Ongoing research into novel pharmacological targets, personalized medicine, and advanced neuroimaging techniques holds promise for the future of TRD treatment. Integrative approaches that combine pharmacological, psychotherapeutic, and lifestyle interventions are likely to be the most effective in addressing the multifaceted nature of TRD. Ultimately, a deeper understanding of TRD and the development of more effective treatment strategies will improve the lives of millions of individuals struggling with this challenging condition. If you enjoyed this video, don't forget to hit that subscribe button and join the Ni655 family. Give us a thumbs up if you liked the content, and make sure to click the bell icon so you never miss an update. Thanks for watching, and stay tuned for more awesome videos.